First of all, I convey my sincere thanks to the organizers, to Dr. Sareen and Dr. Umesh Kapil, who has been with our association and our organization and have been meeting in various forum for quite long time. And my great privilege to also welcome Dr. Saman Singh, Director from AIMS Bhopal. Namaskar, sir. Dr. Surekha Kishore from AIMS Gorakhpur. Dr. PK Singh from AIMS Patna. And I'm very happy to see Professor Ajay Duseja from PGI and be seeing him after many, many years. I think last time I met him wasn't possible in Chandigarh. And all participants from different parts of the country, and particularly from the state of Telangana, where we have faculty members from 12 medical colleges, and that includes the very old institutions like Gandhi Medical College and Osmania Medical College, Apollo and Kamini, and many more. So thank you very much all the participants for joining us. And because the organizers are looking forward to collaborate through AIMS in Bibinagar, in Hyderabad, and then reach out to the various institutions located in different parts of the state, and how we can reach out to the entire state quickly. And so is the arrangement with other states like in Madhya Pradesh and also in Uttar Pradesh and in Bihar. So putting them together, I think this is a very huge task and a very big plan which Dr. Sareen and the team has made. Now the topic which Dr. Saman Singh has already mentioned a few words about the alcoholic and non-alcoholic, probably it has been done with a lot of attention and care, because alcohol consumption is a worldwide phenomena, and how to differentiate it, take it out from that. In the simple words, if somebody, it is written that in the definition, operational definition, excess alcohol. Excess alcohol, it means is 30 ml, which is like a small peg. In simple language, in Indian context, if people who are familiar with a small peg of whiskey, is equivalent to 10 grams. So that's been excluded from the definition, and it becomes a non-alcoholic fatty liver disease. Now, we know that the program of the national level, it was introduced few years back, and that was because the focus was diabetes, hypertension, and at that time it was decided that stroke should also be there. So from diabetes and hypertension and cardiovascular diseases, so the stroke was also added to the national program. Because now, why it becomes a national program? Why a disease should be included into a national program? There are millions, thousands of diseases, and why it should become a program which has to be implemented almost in all over the country. Now, until or unless a disease is so significant that it impacts or either kills a lot, many people, or it is affecting the health of a large section of the population, the government decides based on the data, based on the epidemiological studies and the consequences of the disease, and then it becomes kind of a national program. Probably the ILBAs and many other organizations and others, some epidemiologists, they must have worked a lot on this and brought out the data, and the data which will be shared subsequently, why it should be part of the national program is, it is expected that in our country there will be 20 million cases of NAFLD, there will be 3 million cases of NASH, and 6 lakh patients suffering from cirrhosis, and about 60,000 with hepatocellular carcinoma. Now, this is a big number, which means that this needs attention, and with the growing prevalence of the diabetes, hypertension, and the lifestyle diseases, the nature of this disease and why it happens, and why the diabetes, hypertension, and other lifestyle, these diseases are occurring, increasing over the years, is because the pattern is similar in both these situations. If we see the obesity, diabetes, hypertension, and high triglycerides and low HDL, The data over the last 10, 15, 20 years, if we see, there's a growing trend of the obesity both among women and in men. I just want to share one thing that long back when I was in Chandigarh, I thought that I used to see in the children, there was a change of the food habits over there. A lot of junk food, pizzas and all that started being introduced, and those kind of outlets were introduced, were opening up in Chandigarh. Now, Chandigarh has got a high per capita income. So the change in the schools, the change among the adolescents and their craze for those kind of things, and then watching the students in the adolescent age group in the schools, I could see that something is happening. Then at that time, I thought, let me conduct some studies and do some intervention there. And I did one small project in few schools, and I was surprised that that time I got funding of 5,000 rupees. And people were telling why you're doing it. India is suffering from undernutrition, and why you are talking about the overnutrition or obesity. And then I went to schools and found that then it was scaled up in all the schools of Chandigarh, 102 schools, and reaching to about 100,000 students. And I found that 58.8% of the adolescents in class 9, 10, 11, 12, they were fond of junk foods, and they have been eating junk food. And that is the change which I could see. And now that has gone scaled up. You can say it has reached to even villages now in different parts of the country. At that time, my study, I observed that is in 2002 and 3, 14.8% of the adolescents in private schools and convent schools, they were overweight, and overall prevalence in Chandigarh among the adolescent was about 10%, 9.9%. And at the same time, in the rural areas, this undernutrition was also very high. So which means in a city where there are slums, where there are villages, there is undernutrition also on one hand, which is a major public health issue. At the same time, the overnutrition in a bit well-to-do families or even in the rural areas was also catching up, and it went as high as 15%. So that is what I noticed there, and also try to change the menu of the schools where a lot of junk food was being provided. From there, I went to the Odisha, and then there was a ICMR multi-centric study, and Odisha was decided in Bhubaneswar, because Odisha has got a highest tribal population in the country among the bigger states. About 23% of the population in Odisha is tribal. That was to study the eating habits in the tribal area, what's happening in the tribal areas. The fat, high salt, and high sugar. And we did in 2 blocks, Kandamal, which is this Daringbadi area, Fulbani area, which is called the Kashmir of Odisha, very beautiful place. And that's a very untouched, very far off area from capital, about 8 hours from the capital, Bhubaneswar. And that's called Daringbadi. And the another one is Tangi block, which is close to the Cuttack. Now the interesting findings, I'm just sharing just one or two findings, what's happening in the country, in the tribal area, in such far off area, where probably no teams have conducted the study on the nutrition and eating habits, and including the various changes which we are discussing in today's seminar. The Daringbadi is primarily a very poor area, cut off from rest of the mainstream, where the average per capita income is 150 rupees, and people are living in the primitive and agriculture way of pre-agriculture type of lifestyle, and they have a very low risk of NCDs. Whereas the another tribal population, which is close to the Cuttack, which is a main city, about 1 or 2 hours from there, the per capita income has gone up from 150 to 400 over there, because there are few factories in the outer areas, and they are working, and they are good access of the private sector. Now the difference, if you see, we did, this was with the ICMR, and we did the eating habits. I'm just sharing the pattern of the random blood sugar. Those samples were sent to the NIA in Hyderabad. That time I was not knowing that I'll be working here and I'll be speaking about this. The RBS in the tribal remote area, that's Daringbadi, was only 2.3%. And and it reached to the 8 times increase in the another tribal area, which is close to the urban area, because there was a change in the feeding habits, because there is a change in the profession, there is change in the high consumption of the fats and the oil products. The triglycerides level were 15% in the remote tribal area, and not so remote tribal area, it was increased almost double. It was 28%. The cholesterol levels were 5.3% in the remote tribal area, and it increased to nearly 2.5 times to 12.8% in the tribal area. The major difference was the lifestyle change, the increase in the per capita income, which means the first example I was giving was from the Chandigarh, where the per capita income is high, which means that as we keep on improving on the economic front, we at the same time are also inviting the metabolic diseases like diabetes, hypertension, and the diseases like cirrhosis. Now, this is, I'm giving you an example of a city which we say is a modern and the other which is in such a far off places. But we see the trend which is moved within a decade or say 15 years, where we can see, and even in the geriatric population which we did in Chandigarh, 58% of the population, 60 years and above, they were having hypertension. That was in Chandigarh. So these things are happening, and now what we have to do is we have to see that we are able to address all these diseases together, whether we are working for diabetes or hypertension or in terms of cirrhosis. We have to take them together, because ultimately this is the lifestyle. Students are not moving out. Students are become sedentary. There is introduction of computers, laptops, and iPads, and then the COVID has done further damage to all of us. So this and the junk food, which is become so favorable. I gave the example something like 20 years back. Now students are very fond of that. We need to address all those things and see that all our youngsters. So when we were looking at the operational guidelines which have been prepared, the major things which needs to be addressed is not only at the management at the tertiary level, we have to see at the primary level, at the secondary level, and even before that, that's what we call as the primordial prevention. Even before the risk factors, we need to be ensuring those risk factors are also controlled, which are going to start, which happens right now in the adolescent age group. Even I can say now it must have shifted to even pre-adolescent age group. So we need to address, right, it's becoming a life cycle kind of thing, right from the soon after the birth, when we have the one hand struggling with the undernutrition, at the same time we also have the problem of NCDs and also the problem of obesity. So I'm very happy that I'm being a part of this webinar, and we have, as from the aims in the southern part of the country, we'll be able to address these issues on a larger scale, and it will be my pleasure to be associated with the institutions, Institute of the Liver Diseases, Biliary Diseases, and thank you very much for inviting, and thank you very much all the participants for listening and being with us today. Thank you very much.